thank you speakers for all being here tonight. We look forward to a very awesome talk. So I'll start, and this is in no particular order, but I'm using alphabets because that's just easy to do. So we'll start with Dr. Poteat. Dr. Poteat is an assistant professor of social medicine at the University of North Carolina at Chapel Hill. She's also on the faculty of the UNC Center for Health Equity Research. She's a clinical preceptor for the Gender Affirming Clinic at the UNC's SHAC, or Student Health Action Coalition. She's also a physician assistant in the UNC Infectious Diseases Clinic. Her research, teaching, and clinical practice focus on HIV and LGBTQ health, with particular attention to the role of stigma in driving health disparities. Certified by both the American Academy of HIV Medicine and the World Professional Association for Transgender Health, she is a global leader in HIV research and care with transgender people. She currently serves as the NIH Sexual and Gender Minority Research Office Working Group, as well as the Transgender Training Subcommittee for the Division of AIDS Curriculum Development Committee at NIH. That's a mouthful. She has published numerous articles on HIV among transgender adults and served as a guest editor for a special issue of the Journal of the International AIDS Society on HIV among transgender populations. She's an associate editor for the journal LGBTQ Health. In 2019, she was named to the National Academies of Science Consensus Panel on the Well-Being of Sexual and Gender Minorities. Welcome, Dr. Poteat. Kristen Russell is a licensed clinical social worker at the Duke University Medical Center. She is the lead mental health provider on the Duke Child and Adolescent Gender Care Clinic's multidisciplinary team, which she helped to develop and launch in 2015. She has 10 years of clinical experience with underserved and marginalized populations, including domestic violence survivors, military service members, children with chronic illnesses, and children with special needs, as well as their parents and families. Her recent efforts over the past 5 years have been focused on the care of transgender and gender diverse children and youth. Ms. Russell has been trained by the World Professional Association for Transgender Health. She is now actively involved in training other medical and mental health providers across departments at Duke University Medical Center, focusing on providing informed care and inclusive environments for transgender patients throughout the lifespan. In addition to training providers, Ms. Russell also contributes to the clinic's community outreach and population research efforts. She is a participating member of the Sexual and Gender Diversity Advisory and Diversity and Inclusion Councils for the Duke Health System. And Dr. Dane Whicker is with us tonight. Dr. Whicker is a medical instructor in the Department of Psychiatry and Behavioral Services and the Director of Gender and Sexual Diversity for the School of Medicine within the Office of Diversity and Inclusion. Dr. Whicker received his master's and PhD from Marquette University in Wisconsin. Subsequently, he matched here at Duke University and stayed on for 2 years as a postdoc fellow. He is credentialed as a nationally registered clinical health psychologist and listed as one of 3 of the World Professional Association for Transgender Healthcare North Carolina clinical psychologists who work with transgender youth, and one of 6 that work with transgender adults. He works with a multidisciplinary team across Duke family medicine providers, endocrinologists, psychiatrists, OBGYNs, plastic surgeons, and urologists to provide cutting-edge collaborative care. He works to improve long-term patient outcomes by working with patients and their medical providers throughout their transition processes to establish and clarify realistic transition goals, reduce and manage any mental health concerns, and anticipate and troubleshoot challenges patients may face during the transition process. Additionally, Dr. Whicker conducts formal behavioral health assessments as well as physician and patient-requested pre-hormone and pre-surgical evaluations to assess mental health problems and provide letters of recommendations to pursue transition procedures. In his admin role, Dr. Whicker serves as the faculty sponsor for Duke Med Pride, the School of Medicine's LGBTQ Student Affinity Group. He also leads the School of Medicine's Sexual and Gender Advisory Council, participates on the LGBTQ Community Advisory Board, and works to implement changes to promote LGBTQ affirming care in the larger health system. Welcome all of you speakers tonight. We look forward to your talk. I will now turn the floor over to you all.
Thank you for that warm welcome. I think we're all happy to be here. And I think we're going to take turns, and I'm going to go first, and then Kristen will go second, and then Tonia's going to finish us up, and hopefully we'll have at least some time for questions. And it's just exciting to be in this group of people. So thank you for having us. We're talking about LGBTQ plus affirming care. And this is something that I think all three of us are passionate about. And so I'm going to start by providing some information about just general demographics and, how many people are there that we're talking to, that we're working with in the country. And so right now, the estimates that we have come from the Williams Institute, which is in UCLA Law School. And so their best estimate from 2016 is about 8 million, which I actually think is an underestimate. And we also have, let me see, 1.4 million Americans who identify as transgender. And so what this translates to is about 0.06% of people identify as transgender, or 0.6 people identify as transgender. What's interesting about that is that they're actually cohort effects. And so when we look at people who are younger, they are much more likely to identify as transgender. So the University of Minnesota, I think it was last year or the year before, did a study with over 80,000 9th through 11th graders and found that the number of people in that age spectrum actually was 3%. Of people identified as transgender, and what we're seeing is that these numbers are rising among the millennial cohort, specifically to approaching 10% overall. So this is an emerging population that we want to attend to, and I want to make sure that we kind of are prepared to take care of them. Yeah, so in North Carolina specifically, we have about 45,000 adults who identify as transgender, 0.6% of the population. And of that, 6,600 are 24, under the age of 24 years old. So I think it's important to talk about healthcare discrimination and health outcomes. This is a hard population to work with because insurance, well, for many reasons, but there's not a lot of training yet still in medical schools. There's bias. We have problems with health insurance. And so in this study from, it was conducted in 2015, but it had over about 27,000 participants, so this is huge. And so 13% were refused medical care due to their gender identity and expression. Now, this doesn't necessarily mean that this could be something like, I don't feel comfortable prescribing this, and let me refer you to someone else. So it can be something like that. But what the research is showing is that that's still considered a rejection by transgender individuals. And so the idea would be, hopefully more and more individuals can learn how to provide this care. And so just to put some context on that, because I think it looks not so great. We've got about 28% who postponed needed medical care when they were sick or injured because there's fear of discrimination. So checking in at a front desk and being called by a name that doesn't fit the way that you look or are presenting or that you want to be called. And, kind of the names are really important, which I think Kristen will be talking about later. And as far as insurance goes, about 55% are denied coverage for transition-related surgery. Now, the Health Equality Index has, of last year, made this like a requirement for healthcare centers or hospitals in order to have leader status and get a 100% score for their HEI index. So for those of you in administration, these sorts of things can be relevant. So more and more insurance is covering transition procedures, including Duke. So the last one I'll bring up is 8% of healthcare providers refuse to give people transition-related care. Now, they have not repeated this study, which I really wish they would, because it's almost a decade old, so I'm hoping these numbers have gone down. So you'll see transgender and gender, and TGNC stands for transgender, gender nonconforming. Lesbian, gay, bisexual is in the green. So we're looking at two marginalized groups. And you can see that in the healthcare setting, though there are significant difference between these, it's still the transgender and gender nonconforming who are really bearing a lot of the brunt of this. And then, you know, things from abusive language, excessive precautions, being physically rough, harsh language. So we do have some problems in training, and, you know, I know that we're still developing systems for reporting these incidents at Duke, and it can be difficult. So thinking about health disparities just more broadly, this is what we know from research. We have higher rates of HIV, and I know Dr. Poteat, this is one of her very specialty areas, and so I'm excited to hear what she's got to say. And other sexually transmitted infections. We see lower rates of mammography and pap smear screening among this population, which may make sense because if it causes you dysphoria to even be in the body that you're in, you may be less likely to seek those services even when they're needed. Unhealthy weight control. This includes both restriction and you know, over consuming, and so we see both. And often, what's interesting, when I first started at Duke, which was about 5 years ago, started noticing that some kids were essentially halting their puberty, and their BMI would look fine, but it just stalled, and so they weren't developing. Higher risk of cardiovascular disease. I suspect this is kind of like in public health, you know, allostatic load. Higher rates of smoking, again, probably related. Higher rates of substance use, unprotected sex, less likely to have insurance, and higher rates of trauma and victimization. And so one thing is that there's a disproportionate amount of homeless youth who have been kicked out or rejected by their parents and kicked out of their homes, which puts them at higher risk for trauma. And the other factor is that since insurance doesn't cover some of these procedures, often people turn to sex work or you know, other illicit things in order to get the services that they need, and so it's really, we have a lot of work to do. So, oh, where'd it go? Yeah, so there were the DHSS and CDC, this was an even bigger study, 132,000, 9th through 10th grade, 10 states. The suicide rate here is pretty incredible. So there's about a 42% lifetime suicide rate among transgender individuals. The vast majority of that occurs at the before the age of 24. And so, and as young as 13, I believe it's 8%, if I'm remembering correctly, have already had a suicide attempt among transgender individuals. So what are some of the contributing factors? I know this is a kind of a dark topic to go into, but I think it's important to consider. So the biggest risk factor here is really the interpersonal rejection from family and friends. We have a lot of switching schools. Family members are key. And so this is when I'm talking to parents, even if they are not on board, this is something that we talk about because we see a massive reduction in the suicidal ideation in kids if they have social support, an 82% reduction in risk of attempt. So this is, if the kid wants to go to a camp that's gender affirming, that's great, like do that. Rejected by parents increases the likelihood that they'll attempt suicide by 13 to 19, and even more recent research has gone above the 22%, or 22 times more likely to attempt suicide. So gender-based discrimination increases suicide risk. So if you appear like physically more gender nonconforming, you're more at risk. We do know that, which is why puberty suppression can be so important. Also physical assault, internalized transphobia, and intersecting minority identities. If you're Black, if you have a low socioeconomic status, all of these things, kind of the intersectionality image in the bottom right speaks to that. Let's see. So what are we, how do we define gender dysphoria? I don't know how to make this come back. There we go. So it's the distress and discomfort that occurs when gender identity and the sex assigned at birth don't match. And this usually comes up. There are two trajectories. There's the early onset, which is they're actually finding in pre-K that they're seeing this. So the earlier this starts, the more likely it is to persist. That's one thing that we know from research, which we know we're still working on getting reliable research here in this area. But we're looking for persistence, insistence, and severity. How much distress does this cause? So if you put, a child who is assigned male at birth into a dress, you get a temper tantrum. That would be like a severe sort of gender dysphoric reaction. This does not mean that your child is transgender, but it does mean that there could be some dysphoria. And so really what we want to look at is how does this persist into adulthood and adolescence. So we've got anxiety, depression, eating disturbance, and all of those actually, what I found, especially with anxiety and depression, is that they often really go down when you treat the gender dysphoria. So often it's a byproduct, which is helpful to know. You may try the approach of doing these things together, and sometimes you do need treatment for those individually. And I already mentioned eating disturbances, and I don't want to take up mindful of the time. So this is a word cloud that came up when kind of talking with medical providers about the things that they worried about with treating this population. So I think we're hearing a lot of those. So what is transition? When people say transition, it can mean a lot of things. So I'm going to try and go through this quickly. We have social transition, and then you can frame it a few ways, really, physical transition or medical transition. But so changing name, applying for a legal name change, using the pronouns that you want to use, going out in public, cutting your hair, painting nails, wearing clothes that, you know, are expressing the identity that you wear. And that helps communicate with people on how to treat you. And I know that Tonia, I believe, is talking about binding, tucking, packing later. And so I will leave that. But when we're talking more about medical procedures, puberty suppression was effective up until Tanner stage 3. And so that allows us to pause puberty and really kind of, and it's intended to be used in tandem with therapy to make decisions about whether, you know, minors in particular don't have to go through the wrong puberty, which could lead to irreparable changes. We can't change our skeletal structure, you know, entirely, and even in the face, it's some pretty gruesome procedures. And tracheal shave, mastectomy, hormone replacement therapy, phalloplasty, which we do not have available in the state at this point, although we do have a microvascular surgeon at Duke who does have this skill set. We just don't have a urologist who will help with this. And vaginoplasty, we do have several surgeons in the area who will perform vaginoplasties. So this is a clinical example. So there's a lot of mistrust in the healthcare system because we used to have to, especially with psychologists and mental health providers, because we're the ones writing the letters of referral. So that can keep people away from, alienate people from health care centers in general. So this is an example. Jake R. is a 45-year-old man who came in with pain, and on x-ray what appeared to be metastases from an unknown primary cancer. Evaluation ultimately showed that he had developed cancer in his residual breast tissue after surgery to remove his breast. So he had had a mastectomy, but you still have to check, especially right here, for mammogram for cancer. No one had told Jake that he needed routine breast cancer screening, even though he had a significant family history. And so there is a big chance for medical error, missed things, alerting people for pap smears that don't have a cervix, etc. And so with that, I am going to turn it over to Kristen.
Thanks everybody for being here. One of the reasons we wanted to touch on the health disparities and the mental health concerns is, and the safety concerns, is because this is relevant to the practice that we're all in healthcare, and it really can make a difference. If our patients don't trust us and don't tell us things, we miss important things. And one of the ways to build rapport and gain trust from patients is to use language and terminology that is inclusive, and especially with the transgender community, it's critical that that we understand sort of how to refer to them, how to be respectful towards these patients, and make them feel like they're understood and that they're safe, and that their care is going to be is good, because we definitely have a history in the medical field of not providing the best care for these patients. So next slide, Dane. So with terminology, I know I'm talking to a bunch of doctors here, and you all know what sex is, but how often do we really think about it? And sex and gender are two terms that get used interchangeably, and it gets very confusing, especially for patients and parents. And so it is helpful to kind of think through these concepts as different concepts, and then gender identity being another concept that can be confusing for folks. So I just want to tease these things out and make sure it's clear what we're talking about. So when we're referring to sex specifically, we're talking about, you know, something we're all assigned at birth, consisting of chromosomes, hormones, internal and external sex organs, gonads, so on. Next slide. Gender, on the other hand, is as a social construct. This is something that we as a society, as a culture, kind of created the rules for. It consists of emotional and psychological traits. It's a classification system for, what people do in each of these categories, consisting of roles, characteristics, maybe your places in society, employment, preferences. Women do this, men do that. It's also very much based on a binary, male over here, woman over here, male and man over here, female and woman over here. And so that binary leaves really no mixing in between. A lot of the expectations are you're either this or you're this, and there's nothing in between. And what we are learning about gender and gender identity is, of course, that's not true. And not all women do these certain things based on these certain criteria, and not all men act or behave or have certain emotional traits that are what are expected. So gender is again, a social construct, and it changes over time. It changes with social norms through cohorts of generations. And if that doesn't make sense to you, if you think about women in the 1920s, if a woman were to wear jeans, pants, any kind of trousers in the 1920s, she would have been considered gender non-conforming back then. But then what happened? World War II hit, and suddenly women were pulled into the workforce. They were working in factories. Suddenly it became okay for women to wear pants because they were working in this area, this field. And so the culture shifted and the social norms shifted with it. And suddenly it became acceptable for women to wear trousers, especially in certain situations. And so we've seen this progression occur over time. And that kind of gives you an idea of how malleable gender is. But I want to make sure you understand it's not relying on those characteristics are not relying on anatomy. And so it is important also to think about that gender and sex are both assigned at birth. We don't get a say in this. Genitalia is observed during the birthing process, and sex is assigned. And with that comes the gender. So there's no question. If you are born male, then you are a boy. If you are born female, then you are a girl. And what we're learning, especially the DSD population, children with differences in sex development or intersex individuals, have actually taught us a lot about gender identity and gender, and how we've been getting this wrong, that just because your anatomy says that you are female, that does not mean that your gender identity will be, or your gender would be necessarily woman or female. So yeah, next slide, Dane, thanks. So what is gender identity? This is a self-defined, self-understood, self-realized concept. It's an internal sense of self as a man, woman, other, nothing, in between. It is a core identity. As Dane probably alluded to a little bit, the medical and mental health community for a very long time tried to convince people that they weren't gay, or they weren't attracted to a certain sex, or they aren't transgender. They tried to convince them to change their minds about who they are. And that failed for decades. Lots of conversion therapy, electric shock therapy, medication, institutionalization, none of it worked. And it didn't work because we're talking about a core identity, and you can't change a core identity through therapy or any other means. So when someone knows in their mind that they are male, but their body is saying that they're female, this is what transgender people are, and this is what they contend with. So gender identity develops over time. The awareness of it develops over time, starting from a very early age, 3-4 years old. Kids at that age already know about gender and gender roles. They may not be able to articulate that, but they do understand gender roles and gender norms in their own way, and they do find where they fit in that. And some kids find early on that they don't fit in that, what is expected of them. So next slide. So that brings us to what exactly is transgender? What does that term actually mean? And transgender is actually an umbrella term. It's a broad term, and it encompasses a lot of different identities within it. But it basically describes a person whose sex and gender that were assigned at birth that are incongruent or don't match their gender identity, what their brain is telling them. Whereas a cisgender person identifies and sees themselves, feels that they are, and that identity matches their physical and their sex and gender assigned at birth. So matching versus kind of not matching in terms of like what the body is presenting and what has been assigned. Non-binary identities are something we're starting to learn a lot more about. And again, I talked about that binary structure of gender where there's man over here and woman over here and nothing in between. There's actually a lot in between. And so individuals whose gender experience cannot accurately or sufficiently be captured through the terms male or female, sometimes due to fluidity, identifying as both, neither, or somewhere in the middle. That sort of encompasses what non-binary identities are. Some people, individuals who identify as non-binary may say they are gender fluid, or they are just gender non-binary, or they are agender. But the non-binary identities can be just sort of in that space in between or outside of our social norms for gender and our social norms for this binary that we all kind of live in societally. Next slide, Dane. And all of that is different from our sexual orientation, which is really about attraction, not preference, but attraction, sexual or romantic. Sex and gender identity are independent of sexual orientation. So just because someone is, for example, identifies as gay does not mean they are transgender, or if they identify as transgender does not mean that they also have a sexual minority status for sexual orientation. I mean, we all have sexual orientations, we all have gender identities, we all have a gender that we were assigned, all of us have these things, whether it's cisgender, heterosexual, gay, we all have these identities. It's just minorities kind of get put into, unfortunately, a separate category. But it is important just to understand that these concepts are different. They mingle in with each other, and we use them a lot of times interchangeably, but they are separate concepts. Next slide, the one before, yeah. So I was talking about that binary, and this is a kind of a linear way of looking at it, but you're seeing biological sex, gender identity, expression, presentation, and sexual orientation all have all this space in between these two sort of binary poles. So this is one way of looking at all the degradations between male and female, all that space in between. People can occupy all of that and outside of it too. But this is one way to kind of look at it and understand. It is linear though, and so what I find more helpful is the next slide, which is more of a spectrum cloud. And thinking of gender and sexual orientation, gender identity in this way allows us to see people multidimensionally. We occupy more than one space at the same time. And instead of trying to put ourselves on poles, we actually mix and meld these things all the time. Gender expression, gender identity can be much more than just these little gradations in between this kind of linear pole line. So that's just an image to kind of bring that home. And next slide, Dean. So now we sort of understand a little bit about terminology and just the differences between the different concepts. It is now important to talk about pronouns, and pronouns are so critical. I can't express that enough because they really are a form of validation, and there is no better way to make someone feel unheard, unseen, not included, like you don't care, than by not validating them through their pronouns. So I want to stress this as much as possible. And there's different ways to ask about pronouns. There's different ways to tell people your own pronouns, which is a good practice to get into. I definitely use this This second one, hi, my name is Chris. My pronouns are she, her, hers. I am your social worker today. What pronouns do you use? Or how would you like me, what name would you like me to use? So you can use, these are just some examples. But it definitely can get a little confusing, especially if you're caught off guard with an insurance card or a medical record that doesn't match what the patient just told you. It can cause a little bit of confusion. So in those moments, you know, I usually advise just kind of slow down and ask additional clarifying questions in a respectful way. You know, is there a possibility that I'm missing something here? And just being very careful and cautious not to misgender someone or use the incorrect name. Plural pronouns are difficult, they're challenging, and I know a lot of providers really struggle with that. But I promise you the benefits of practicing and using the correct pronoun are far outweigh the risks of not doing it. It's really important that patients feel like they can trust you, and that if you can get the pronouns right, and it's okay if you mess up. We'll talk a little bit about messing up later, but if you can get pronouns right and you can validate people, and it shows that you respect them and that you're trying and that you understand, and you have at least some knowledge of the care that they may need. So next slide. These are just some examples of pronouns. Often, you know, in the gender clinic, I've seen one patient that used Z, her, hers. Most of the non-binary patients I've ever met use they, them, theirs. And then there are, of course, the other pronouns, the binary pronouns. Okay, next slide. Going back to just kind of keeping language, being careful about language because it is powerful. There are some things that you definitely want to avoid saying when interacting with transgender patients or gender diverse patients. Using words like real sex. You wouldn't want to use that term. Instead, you would use sex assigned at birth or assigned sex at birth. These are some examples. You can go back and look at these later. I can make sure that these slides are available to you. For time, I'm just going to move on to the next slide. These are some additional terms to really avoid, both in the presence of the patient and outside the presence of the patient. So you're just making sure you're not using these terms at all. Okay, next slide. I think I already kind of covered some of this, but in terms of, you know, how to introduce yourself, but when you're asking about sexual identity and sexual orientation information, I know at Duke, we're starting to collect that information, that data. We call it SOGI data. Because it is important that we understand our population, who's coming to see us, how many people are coming for services. So these are just some examples of some ways to ask questions to kind of get at those questions and make sure that you're documenting that in the appropriate place in the medical chart or however you use it, whatever institution you're in. Next slide. And then of course we're human, so we're gonna mess up, and it's gonna happen. It's happened. I've been working with trans youth for a long time now, lots of them, and I still mess up occasionally, not as often as I used to, but it's critical when I do that, and when anybody does that, that you don't blow it off and don't pretend it didn't happen and just try to keep on going with the session or with the interview or the visit. It's really important that you acknowledge that what you've done, apologize, correct yourself, and then move on with the conversation. Don't harp on it or continue to kind of, I'm sorry, oh my gosh, I can't believe I said that, I didn't mean to. It's really important to just kind of move on and then just be mindful of trying not to do it again. And you may do it again in the same visit, again, apologizing and then really trying to get it right. And if you find that you're really struggling, especially with, you know, they, them, their pronouns, it's okay to use the patient's name instead, but it is important to try. And again, patients notice when you're trying and when you're making an effort and when you're not. So just to kind of keep that in the back of your mind. Also, some just tips. It is really not okay, not appropriate at all to ask transgender patients about their genital status or any transition-related procedures that they have had if it is unrelated to their care. And it's unfortunate that I even have to say this, but I have to say it because it's happened, and it's happened at Duke, and it's not appropriate. And these are the things that make patients not want to come back and not get care when they actually need care. So we really want to be respectful, and that's just, if it's not important to their care, you don't need to ask about it. You don't need to know. It's also important not to disclose whether a patient is transgender to anyone who does not explicitly need that information for their care. This is especially important for some youth if they come out to you, that you're careful that they may not be out to their parents. They may not be out to a caregiver, and you could actually put them in a little bit of jeopardy if you out them in front of people that they're not ready to be out to. Can jeopardize their housing, employment, numbers of other things. So just 2 important tips I wanted to share with you on that. Next slide. So there are some other things that you can do to kind of make, in addition to using, inclusive language and terminology, and that is, visual cues. Visual cues are a great way to show patients before they even meet you that they're safe with you, that they can talk to you about their concerns, especially if they're gender related, and it's okay that even if you don't have all the answers, you're going to find a way to find them and get the resources that you need. But these visual cues let patients know, and they find them, I promise you, they see them. And it means a lot to them. And if I had the time, I would tell you a story about that, but I'm worried that I don't have the time. So if you can put pronoun stickers on your badge. You can put these kinds of signs out on your door. We put a safety sign with a rainbow on all of our patient doors during clinic days, so that they know that when they go in that room, that is a safe space for them to talk about whatever they need to. Next slide. Take a look at your forms and your documentation and just make sure that it's inclusive. I think Dr. Poteat has some examples of some forms too, some things that can go on forms. And there's lots of examples of this, but just take a look at them, make sure that there's a place for patients. That shouldn't say preferred name, that should say chosen name. Sorry about the typo there. And a place for them to put their pronouns and other important information that is inclusive of everybody. Next slide. And then these are some places to get more education, more information, more resources. The WPATH Standards of Care Manual is available online. The Endocrine Society guidelines are what we use, obviously, but we're providing specific trans-related care. But if you do have a patient that is needing this care, these are the resources to go to get it. I think next slide might be one of the last ones. Oh yeah, and also, I don't know where all of you kind of practice, but making sure that there's a policy, and if there isn't one, establish one, and make sure that there's a way to enforce it. Of addressing just discriminatory comments or practices that may come up in your practice. That goes a long way to making an inclusive and safe space for patients. Next slide. I think that was it for my portion, and I think we might need to jump right into Dr. Poteat's, and then maybe questions at the end, if I'm not mistaken.
That's fine with me, if that's what works for everybody. Can you hear me?
I can hear you.
Yes. Okay, good. Sometimes you're just like, am I talking to myself? What's happening?
I breezed through that really fast. I hope I wasn't keeping a good track of time. So I hope I left you plenty of time, Dr. Poteat.
Well, there's never enough time to talk about sex.
That's right.
So I'm excited to talk with you all tonight. I have to say, when we were planning this, I was saying that sex is my favorite thing to talk about. And partly because it's something that I know. I trained at the Emory PA program in the early 90s, and we didn't get a lot of great education then around how to do a sexual history period, much less how to do one that's inclusive. So it brings me great joy to be able to talk about it all the time. But I do talk about other things. So I just wanted to start off with reminding us why we ask all these nosy sexual questions. Kristen made the really good point that you don't want to ask just because you're curious, and you certainly want to share information about a patient with someone who doesn't have a need to know. But there are really good reasons to take an accurate and thorough sexual history. And just as a quick story, I lived in Maryland for 10 years before I moved back to North Carolina a couple years ago. And I had a patient who came to see me at the community health center where I worked, who had gone to the emergency department, had gone to see a dermatologist because she had this rash, and then she started losing her hair. And no one had asked her about her sexual history, and nobody had tested her for syphilis. And she thought I was like the angel from heaven because I tested her for syphilis and gave her a shot of penicillin, and she was like, "You're a miracle, you're so brilliant." And I was like, "Yeah, I'm super smart." So just to keep in mind that it is really important to the health of our patients that we ask these questions. We want to ask the kinds of detailed questions I'm going to talk about because we want to know if they're likely to have a sexually transmitted infection, and if so, where, so we know where we should screen. We want to know if they're likely to be pregnant, if they want to be pregnant, if they need contraception. We want to know if they have any sort of sexual dysfunction. Are they having pain? Do they need referral to a specialist? So those are some of the reasons that we ask. And it's important to do that in primary care as well as in subspecialty care like HIV. So how do you get started with that conversation? I think just to review some of the things that Kristen said around how to get started in a way that's inclusive of everyone is if you have forms that ask those questions for you, then I remember, especially when I was in my early years of practice, it always felt better to sort of look at a form and look at the patient and look at the form and look at the patient so that I was like distracted. But it also gives you information that you don't have to then ask the patient necessarily because they've written it down for you. What is this says preferred name. I agree, chosen name is much better. I couldn't find one online that was an example that said chosen name. As the patient said to me, it's not the name I prefer, it's my actual name. So just remembering that, asking for their pronouns, asking about their sexual orientation, and maybe more questions about what that means to them if you use these labels. Also forms that ask about gender identity separate from sex assigned at birth, offering people the option not to answer and to fill in whatever is most appropriate for them. For those of you who still have paper forms, it can be nice. I know I spent many, many years trying to get EPIC, which is a system that we use, the module that asks more inclusive questions. And then I moved to North Carolina and UNC had it already, and it was joy to my life. So those can be really helpful as well. But if you're just having a conversation with the patient, you can also just ask them. And this is the language that I use, and I practice using it until it becomes really comfortable because it can feel awkward if you're not used to saying it. We're just like, "Hi, my name's Dr. Poteat. I use she and her pronouns. What name do you prefer that I call you? What pronoun do you like me to use?" And this actually works for every patient because I grew up in North Carolina. I have about 4 nicknames that none of you are going to hear tonight. So many people have names that are not their legal names or not their insurance names, but names that they want to be called. So just asking people, what name do you want me to call you while you're here, and what pronoun do you want me to use, can just become part of your routine practice. Then there's the question about, before you start asking people about sex, should there be a preamble? Should you start introducing that you're going to talk about sex and get them ready and get yourself ready? It can be helpful if you or the patient might feel awkward. It can help to remind you why you're asking. Like I have said things like, I ask all my patients about their sexual health, just to remind them that I'm doing it and me that I'm doing it. But if you spend a long time on the preamble, like I'm doing right now, it can suggest that it's a somehow shameful topic or different from the rest of their health history. So finding that balance can be really important. I do say things like, I ask all my patients about their sexual health. Is it okay if I ask you some questions? And if it's a patient you've had for a long time and you realize, the last time I took a sexual history was 10 years ago, things might have changed. To say something like, I know I've asked you before, but I want to update your sexual health, or our clinic is trying to be more consistent about asking patients about their sexual health, things like that. I stole this little top thing from Christopher Hurt, who's a physician at UNC, because I thought it was the cutest thing ever, the little eggplant, peach, bananas, donuts, and then the universal sign for I don't know what, right-hand sign. So you'll see that recurring because I think it's cute. But the CDC has guidelines for what we should be asking people when we ask a sexual history. So this isn't just my personal opinion. It's actually guidelines from the Centers for Disease Control and Prevention about what are the topics that should be covered in an inclusive sexual history. And that includes asking about partners, asking about practices, what people do, asking about if they've had any history of sexually transmitted infections, asking if they do anything to protect themselves from sexually transmitted infections. The CDC guidelines say pregnancy plans. I changed that to parenting plans because not everybody who's planning to parent is going to be pregnant. And I dare you to say that 5 times fast to see how many P's you can get into that sentence. And some people add a 6th P for pleasure. And that is the most common reason that people have sex. So I think it makes sense to ask our patients about that as well. So I'll go through each of the 5 Ps. And I think we'll have lots of time for discussion at the end because I am really interested in your questions and a conversation. So in terms of asking about partners, I tend to use broad terms, not say, do you have a boyfriend or do you have a girlfriend? Because that makes some assumptions about the patient and about the patient's partners. But how many sex partners have you had, you know, since we last met or in the last 12 months? I got trained to ask people how many sex partners they've ever had. And then I realized I don't need that information. It doesn't help me make any sort of assessment whatsoever. They could have had 100 partners in 1 week 10 years ago, and that doesn't tell me a thing about what they need today. So recent sexual history is going to be what's most important. Have your sex partner or partners changed since your last visit? And then asking, once that conversation has begun, about what are the genders of your sex partners, or how many sex partners do you have, and those kinds of questions. But opening the door with something broad and not gender specific. Then you want to know about their practices, and this tends to be where it's really hard for people. I remember a student cohort member of mine, we had our 20 minutes of sex education for PA school, and then we watched a film. I can't believe this happened in Georgia, but then we watched a film about orgasm to help us understand the stages of orgasm. And I thought she was going to die. She literally left the room. So she couldn't say the word penis. And I think for many of us, I don't know how many of y'all grew up in the South, but I grew up, you know, I live in Durham. I grew up 30 miles from here in Alamance County. And I couldn't say those words for a really long time. It was just not how I was brought up, and we might not have gotten it in our training. So having some practice. I practice with my cats because my friends don't really want me to ask them all these questions. But asking people, like, tell me about the kinds of sex you have. And you don't have to mention any organs when you do that. As the conversation progresses, people might want, you might need to ask more specific questions about what went where, so you can understand what that person's risk is of pregnancy and their risk of other sexually transmitted infections. You can also say something broad like, what might expose you to other people's body fluids? What might expose other people to your body fluids that you do sexually? And then that could help open a door. And you would also get a sense of the words that the patient wants to use when they talk about their body parts. I used to, in these trainings, say that you should always mirror the words that patients use. And then I realized there are some words that patients use that I'm not going to use. It's just not consistent with the language that I use in general. But also, a friend of mine did this really amazing study with trans men. About 1,800 of them completed an online survey, and they were asked, would you want your healthcare provider to use the words that you use for your anatomy? So for example, a lot of trans men refer to what we would call a vagina as their front opening or their front hole. And about 2/3 of them said, no, I want them to use medical language because I'm in a medical setting. So asking the patient what words they want you to use can be really helpful in following that guidance. I was also trained for many years on asking, do you have sex with men, women, or both? And I think Kristen did a great job of describing how many people that leaves out if you ask that question in that way. And so it was super progressive when I was in school in the 90s. And now that we have a better understanding of the breadth of gender and gender identities, it's a question that suggests to the patient that you haven't thought about people who might not be identified as men, women, or both. When you're asking about past history of STDs, that can be pretty straightforward. Have you ever had symptoms of an STD? When was the last time you were tested? When was the last time your partner or partners were tested for STDs? And I think it can also be tempting to assume that there's only one partner, particularly if you have a patient who is married or in a long-term committed relationship. But people can also have varied relationship configurations, agreements, things that are not agreements but involve other partners. And so presenting the questions in a way that is without judgment can be really helpful in getting accurate information. In terms of protection from STDs, I think I was trained to ask people if they used a condom. That assumes that there's a penis always in the mix, which isn't always true. And there are other ways that people might protect themselves from STDs, especially now. And I stuck a little slide or two in here to talk about some of the advances in HIV prevention that we have in particular. So I ask people, how do you protect yourself or your partners from sexually transmitted infections? How often do you tend to use barriers like condoms? And very few people are super consistent, so I like to leave the door open to the fact that they are more likely human beings and sometimes do and sometimes don't, and then ask them to talk to me about times that they don't and times that they do, so we can brainstorm together if a priority for them is consistent condom use or consistent barrier use, what are the things that get in the way? And then ask if they've ever taken pre-exposure prophylaxis. And if they haven't or have no idea what you're talking about, asking if they'd be interested in learning more about a pill that can prevent HIV. And this is where I take my little divergent road to the right and talk about PrEP. So PrEP stands for pre-exposure prophylaxis. The first medication for pre-exposure prophylaxis was approved in 2012. It's a medication called, the brand name is Truvada, and you'll see it there. It's tenofovir is the main ingredient. And then just last year, a second agent was approved called Descovy. It is almost the same as Truvada. It's a slightly different chemical structure, and that chemical structure reduced some of the concerns that people had about the impact of this medication on bone and on renal function. So there's two medications, virtually identical, both safe and effective to prevent HIV. Both of them are approved to take one pill once a day. These medications are also medications that are taken by people living with HIV as part of a combination of medications. So this is really important. I've talked to some, unfortunately, some patients who had primary care providers who were not familiar with PrEP. And so they saw that the patient was not living with HIV and saw that they were taking what seemed to them this random HIV medication. And they said, you don't need to take this medication, you don't have HIV. So that's why it's part of my mission in life, is to make sure that even if you're not somebody who feels comfortable prescribing PrEP, and I encourage you to be comfortable because it's super easy. If you can prescribe birth control pills, you can prescribe PrEP with great ease. But even if you're not, to recognize that someone might be on one of these medications to prevent HIV. And then, not FDA approved yet, but probably will be approved in the, I'd say probably the next 6 months or so, is a medication called cabotegravir, long acting. I don't know what the brand name is going to be, but it's a injectable agent that's injected every 2 months and has also been found to be effective in preventing HIV. So some people have concerns about if there's this pill that people take every day or a shot that people can take every 2 months, does that mean they'll stop using condoms? And I would just say that some people don't use condoms already. That's why we have sexually transmitted infections and why we have HIV. And so having other alternatives that are more acceptable to people is really important. And then some people really appreciate the protection that comes from using both condoms and using an oral agent or an injectable agent. So the condoms protect them from skin-to-skin sexually transmitted infections, and these other medications protect specifically against HIV. Okay, almost to the last P. The next last P is, what are your parenting plans? And I ask that rather than pregnancy, because if you have a patient who has a penis and maybe they can't become pregnant, they might have plans for their partner or partners to become pregnant, and knowing that will be really helpful as you make decisions about their health care together. And then, would you like to be a parent now or in the future, will be helpful, because maybe they're not planning to be pregnant or planning to parent immediately, but that's a long-term goal. And especially if you're thinking about providing gender-affirming care for people, having those decisions around storing sperm or storing eggs and things like that can be really important because of the effects of exogenous hormone therapy. So for someone who has a uterus, I might say, when was your last menstrual period? Is there any chance you could be pregnant now or in the future? What do you do to prevent pregnancy if they don't desire to be parents? And I say for someone with a uterus, not only because we're talking about gender diverse populations and trans men often will retain a uterus and have the potential to become pregnant, but also as I'll overshare, as someone who doesn't have a uterus and identifies as a woman and didn't have a uterus for a long time, being asked this question can be really annoying over and over again, and having people to test you for pregnancy and assume that pregnancy is a concern of yours, when I think not making that assumption can be more helpful and lead people down a correct path faster. And then some other questions that you might want to consider asking about are pleasure. Are you happy with your sex life? Can be just a general opening question. And then digging deeper into, do they have challenges with libido? Do they have challenges achieving orgasm? Do they have trouble with erectile function? Those kinds of things. And if it's not in your wheelhouse of things that you know how to handle, at least you know you can refer them to a gynecologist or refer them to a urologist, and make sure that they get the care that they need. And then I always ask if people feel safe with their partner or safe in their relationship. And that's a sort of I think many gynecologists ask that question when they're providing care, but I think it's something we forget in primary care and in other kinds of care to assess physical safety and emotional safety within relationships. Okay, it is really important that every single person has something that they find icky. I think not everybody likes the same food, not everybody likes to hear about the same sex. All of those things are true. And you can't get rid of feeling icky about some sex acts by pretending that you don't have any. So I love this because it's basically your job is to fix your face, right? Just to make sure that you're not communicating any of whatever you might be feeling inside about someone's sex acts to them. And that can be quite a challenge, right? You might just be caught off guard and be surprised. But I think it's worth thinking through how you can cultivate a calm demeanor no matter what people tell you. And then the last couple of slides are really about a sensitive physical exam. And some of that involves getting information before you see the person naked and thinking about how you talk about their bodies. So I won't go over this in detail, but on the left-hand side are some of the gendered words that we tend to use when we're describing people's body parts. And on the right-hand side are some options for less gendered language that you might use with a patient whose gender identity is different from their sex assigned at birth, people who feel uncomfortable with that. And honestly, some of the words that we use, our patients have no idea what we're talking about, right? Like even the word vagina, we assume that people know what we mean, but often people have no idea what we're talking about. So using something that's just more specific or more lay language can help with communication as well. And then as much as I can, I try to use gender neutral statements when I'm talking about something. So if I'm asking about pregnancy, I might say I ask this of everyone with the uterus, so that they know I'm not projecting a gender on them. I was excited to see our EMR has an organ inventory form. I was not excited to see that almost nobody knows that, and so nobody completes it. But if it's available to you, it can be really, really helpful. For one, it helps prevent embarrassment when you're doing an exam and you might stumble upon something you weren't planning to see. Being prepared can be really helpful. Also, as Kristen mentioned, people who have differences of sex development may have body parts that you don't anticipate them having. So they might have both a penis and a vagina, for example, or some other configuration of anatomy that we're unfamiliar with. And doing an organ inventory can be very helpful for that. Same for transgender people who might have had some sort of hormonal or medical intervention. And it's important to keep in mind a couple of things that I think people often don't know around gender affirming surgeries, that if someone's had a vaginoplasty, unless there's some reason that they've had their prostate gland removed for BPH or some other reason, they will still also have a prostate. And I have found that when I do prostate exams with trans women, it can be very affirming to do so in stirrups. I know it's shocking, like most women are like, ah, stirrups, but actually many of the trans women I've provided care for, it's both easier to access their prostate through a vaginal exam if they've had vaginoplasty, and it's also affirming to do so in that way. And for transmasculine people who've had a metoidoplasty, which I think in lay terms is often called a clitoral release surgery, they can still have a vagina. So you can have both a vagina and the penis, and being prepared for cervical exams if somebody needs that is important, even if the person has a penis. So importance of organ inventory. And then the last couple slides are just going to be about things that people can do on their own. I think when we ask people to take their clothes off and you'll be right back, we have some assumptions about how long that takes. Well, sometimes that varies depending on what the person has had to do for their gender affirmation before they get there. So on the far left, you see somebody who is wearing a binder, and this is sort of a professional binder. And that's a garment that's used to flatten the chest for a more masculine appearance. Official binders are available on the internet, and I assume in some stores, but people also use sometimes double up sports bras, they use ace bandages, there's various items that people use for binding. And there's a person who has a whole body of research on looking at some of the health effects of binding. And so just asking about whether or not someone binds can be a really important part of their health, and if they're having any health effects that they've noticed associated with that, and then helping them navigate any sort of skin changes or breathing changes can be really useful. And I can make sure we share some resources about safer binding. But you see on the far right, and the bottom cartoon is an example of tucking. And that's where someone tucks their penis and their testicles sort of back and up to create a flat appearance to the pelvic area. And I always tell people this is not only gender affirming, but it can be a matter of safety as well. If somebody's wearing a mini skirt and they have a bulge in front, it can often be an excuse that people use for violence. So that's really important. People hold the penis and the testicles up, sometimes with tape, sometimes with a garment called, I call it a goth. And you can see there's really fancy ones you can buy. So on the upper far right is a goth that you can buy that also creates the appearance of a vulva. In case you want to wear pants that are tight enough for people to see your vulva, you got that, you got that down pat. On the bottom left, you'll see that what sometimes people use for packing or packers. This one is one that's designed to create the appearance of a penis in the pants, but also somebody who wants to urinate standing up at a urinal, for example, would be able to use this device, also called STPs or stand to pee. And then in the middle, you'll see someone with a needle going into a breast. So that's a picture that's reminding me to talk to you about silicone injections. And it's not uncommon for trans women, particularly in urban areas. I haven't really been in North Carolina long enough to know that this is common here, but definitely when I lived in New York and when I lived in Baltimore, many trans women had injections of soft tissue fillers, which they assumed were silicone and may or may not have been silicone. They may have been Crisco or water or industrial grade silicone or all sorts of fix-a-flat, I've even heard, to feminize their appearance. And it's not a safe practice by any stretch of the imagination. This is loose silicone or other fillers that go under the skin. They can migrate and cause ulcerations. They can cause acute respiratory distress. There's all sorts of negative effects associated with it. The benefit that people who do it see is that they immediately get the body changes that they need to affirm their gender. And it can be very affirming to be like, okay, so in the next 30 minutes to an hour, I'm going to walk out of here and I'm going to be perceived as the gender that I identify with because I have breasts. And it's important to keep that in mind when we think about counseling patients on safety and harm reduction. Okay, so I'm going to close with just some tips about doing sexual health history and a little anatomy history questions, that using a trauma-informed approach is super important. We know that LGBTQ patients are more likely to have had previous negative healthcare experiences. I think that was covered very beautifully already. We know that sexual abuse and trauma is common in this population. Developing trust and rapport can take longer than usual. You could be like the nicest, sweetest person on earth, but if they've seen like 20 people who are nice and sweet and then misgendered them or treated them poorly, it's going to take you a lot longer to get to that trust and rapport, even if you're fantastic. Using principles of trauma-informed care, I always ask permission for any aspect of the exam, and I have done many creative collaborations for exams that people feel uncomfortable with. Like what does it take for you to feel comfortable participating in this exam that's really important for your health but might cause you some dysphoria. We talked about language for their anatomy, using gender-neutral terms, and avoid using possessive pronouns. So even if you use medical language, like for example, you're examining a transgender woman, referring to it as her penis and saying your penis multiple times during the exam can be really psychologically traumatizing to people. So sometimes even a little dissociation like the penis can be helpful for people experiencing dysphoria. And then I'll just reiterate, be consistent as you can with pronouns, names, and gender markers. And if you make a mistake, apologize and move on. And the general principles to keep in mind is to make sure that there's confidentiality of whatever the patient tells you and whatever you see in exam, using matter-of-fact, simple language as much as possible, and trying our best to show no judgment and make few assumptions. I used to say be non-judgmental, and then I realized like people are judgmental. Like that's what we do. We make judgments all the time. Is it going to rain today? Should I take my umbrella? Like even this simple as that. So making sure that we don't show our judgments to our patients is very important, and making as few assumptions as possible. And I think that is it. Hopefully that was, okay, good. We left like 10 minutes for a conversation.
So great, that was an awesome lecture. I wish we had more time to go over, this is a lot of information, but I want to open up the floor right now for any questions from the audience. There were quite a few questions that were thrown about into the chat discussion. I encourage the speakers and everyone to read those. If the speakers wish to address those right now, that would be great. Otherwise, I will open it up to people that are on the phone call if they have any questions spontaneously.
I can take the first one from Keely. So given that transgender is not technically a sexual orientation, are trans individuals left out of legal protections specifically targeted at sexual orientation? And so for that question in particular, we do not have any federal protections against people for sexual orientation or gender identity. And so there was Title IX used to be used to provide protections for transgender individuals. However, with changes in administration, that's been reinterpreted and is continually challenged. But currently in North Carolina, we do not have those, we don't have the legal protections for those. However, at Duke and I believe UNC as well, it is added to the Title IX protections at those institutions, so that sexual orientation, gender identity, and gender expression are all considered protected the same as someone's gender, race, ethnicity. And so it's policy right now that's driving that.
Yeah, and I'll add also, I lived in a state that where sexual orientation, before I came here, that sexual orientation was protected by state law, but gender identity was not. And it took an additional 5 or 6 years before the state legislature was convinced to add gender identity. I mean, we're in North Carolina. Everybody remembers the Battle of the Bathrooms, I'm sure. So it can be a different set of challenges, I think.
So I do want to say that to everyone on the call right now, we are recording this, so it will be archived later for later review. And I also want to ask the speakers if you guys are willing to share the slides, because obviously this is a lot of information very quickly. I'm sure some of us want to review this later, so if you guys could share those slides with us, that would be great. Otherwise, let's continue with questions.
Somebody asked a prep question, and it was a good question, and I want people to ask me all kinds of questions. The easier the question, the better, because then I can feel really smart, like my patient who had syphilis, and I just gave her a shot, and she thought I was like, the smartest person on earth. So is PrEP, the question is PrEP affected by partner's HIV status, viral load, that kind of thing? And that's actually not a bad question, because there are these criteria that CDC has for who is eligible for PrEP. I feel like anybody who wants PrEP is eligible for PrEP, in my opinion, but it is generally used to prevent the HIV virus from being able to establish infection in the person who's taking it. So if their partner doesn't have HIV, then PrEP. Actually, PrEP has been found to be effective against herpes as well. People don't talk about that so much, but Truvada is also effective against herpes, but it prevents it from getting in. If a partner does have HIV and they're undetectable, people might have heard the term people use called U equals U. So if somebody has an undetectable viral load sustained for a long period of time, they cannot transmit HIV to their partners. So technically, a person would not need to be on PrEP if their partner was undetectable. My feeling is that's a lot of press to put in somebody else's health care for themselves. And so it's reasonable for someone to also want to be on PrEP if they have a partner that they know has HIV, even if that person is on HIV medication and they have a viral load that's undetectable.
I have a question to Dr. Dane Whicker concerning the contributing factors for suicide. Could you speak a little bit more about the internalized transphobia?
Yeah, so and that's more of a psychological concept, but essentially it's taking beliefs that are perpetuated by society, parents, religious organizations that being transgender is wrong, or you know, against the religion or against my parents' wishes, and internalizing that as and making it part of your own belief system. So then you're essentially kind of telling yourself that I'm a bad person because I'm trans. I'm not as good as I should be. So that's what that means.
Is acceptance by family more important than acceptance by others pertaining to contributing factors?
Yes, and this is something that I talk to parents a lot about, and I say you have the opportunity to be probably the biggest protective factor for your child if you can support and affirm them and who they are. And the flip side of that is you can also be the biggest risk factor.
Sure.
So, you know,
Thank
you.
Thank you very much.
I also want to add to that, you know, I talk to a lot of parents as we're, you know, a lot of the patients that come to see us are children and youth, and they're interested in considering a transition with a transition step or effort with the use of hormones. And, you know, parents have a lot of fears about that, of course, and concerns and questions. And I often kind of reiterate what Dane just talked about as the protective factor of, look, it doesn't mean that you have to understand or accept everything or know everything. It just means that you're supporting your child and you're trying to figure it out. That's the protective factor. It doesn't necessarily mean that they're going to agree with everything or understand it necessarily. And that's my job, is to help sort of bridge that information gap for the parent of what dysphoria is and what that actually feels like. And we talked about it really briefly in the presentation, but it's really a toxic emotion, if you will, and it really treatment helps, and so getting parents to kind of see that side of it can be really helpful for the patient. There was also a question about confidentiality, particularly with minors. I guess it depends on what you're talking about, but when it comes to transgender, you know, if they're coming out, it's important to keep that confidential from parents. If they tell you that that's what they need you to do, it is important to ask, like, do your parents know?
Well, I had a student from UNC during my training in psychiatry who presented with depression, and part of it was that his mother was expecting him to get married, and she did not know about his gender identity. And when I asked him to inform, and when the mother accepted his gender identity, he did not need any medications for treatment of depression.
Mm-hmm. Yeah, well said. But that needs to be on the patient's terms, in terms of when they come out, how they come out, if they come out. So it's just important to kind of keep that in mind with youth, just being very careful with that confidentiality and helping them to get to that point where they feel comfortable coming out and they're safe to actually do so.
So Kristen, is that so I know right now there's an age limit on that. Is this now still covered no matter what age they are, if they're 12 or 8 or?
When it comes to them disclosing a gender identity or sexual orientation to you, yeah, the parents really, you really have to be careful with that. The parents, I'm not talking about providing a treatment without parent consent. I'm talking about if they disclose something to you that they do not want their parent to know, it's important that you respect that confidentiality. If they say, I think I might be gay, doc, but my parents don't know, I will be kicked out of the house if they find out. It's just being very careful to, and they may not say that to you, but that might be what happens. So just the law is not going to cover that part of it. That's just confidentiality between you and the patient. We're not talking about, of course, if you were going to start a treatment of some kind specifically, you would have to get the parent involved unless it has to do with pregnancy and reproduction. That's a different kind of category. But right now I'm just talking about, self-disclosure of an identity, a sexual or gender identity.
I'm the person who asked that question. And the reason I brought it up was because in primary care, I knew that for a while it was the last that I had checked down to age 14, if kids ask you questions about sex or alcohol or drug abuse, we had that confidentiality protection so that we could give good care and give good advice to our pediatric patients and our kids who were minors. So I was just curious where, if those have changed. I mean, I know we've seen a lot of changes in legislation lately and with the nature of where our legislature has been in the last 4 to 6 years. If that had changed at all in terms of the protections for physicians who are trying to protect their patients who are minors, trying to give them a safe space to be able to protect them from STIs and drug use and that sort of stuff. And if you had any insight in that, if that's changed at all, or I know that I actually was in situations where I had to tell parents, I will not tell you if your child is having sex or if your child is doing drugs unless I feel like they're in danger, because that was the law.
Right,
So.
and to my knowledge, that has not changed.
Okay.
The key is safety and danger. Yeah, that you're required, obviously, to report that, whether it's self-harm or sexual violence or something like that. But yeah, it's using your discretion that way. But also just the law, as far as I know, has not changed on that regard.
And in psychiatric, we also, like in psychiatry or mental health, if you're in one of those departments, we have, at Duke, we have a special firewall so that other providers cannot see into the psych notes. And then if we get a medical records request, we can provide a summary, but we do not have to release records for that age range.
Oh, interesting.
So
and that goes down to what, 14?
I thought it was 13, but maybe I'm wrong.
Okay. No, you might be right.
Yeah.
I haven't treated a kid in a while, so I trust you more than I trust me.
I'll have to look it up.
Thank you.
To Dr. Tonia Poteat, I do understand LGBT, heterosexual, homosexual, transgender. What is the other? Or I'm just trying to understand. I'm trying to wrap
in the list of sexual orientations, what was the other?
Right.
People will surprise you. I never cease to be amazed at how people select their own language. I'm a survey researcher in most of my life now, and I once had somebody write fuchsia. That was their sexual orientation. I was like, and that's what I thought of, Kristen, when you showed that picture of the brain with all the colors and the arrows. I was like, yeah, so your sexual orientation's fuchsia.
Okay.
Prince was a symbol.
There you go. You could be anything.
So just to be mindful of everyone's time, are there any last questions? Of course, we're going to try to, I think we did record this, so this was a great talk, by the way. Thank you to all the speakers. Thank you to everyone who participated in this. This was a great talk, being our first virtual meeting. Again, as I said before, I think it's going to be an adjunct to our future meetings. It may increase viewership. But thank you so much to our speakers. You guys were awesome.
Can I ask one more?
No.
I want Kristen to tell her Safe Spaces icon story. I want her to tell her story that she said she didn't have time for, where they see the little icons. I can't wait to hear that story. I love those. That's a good way to end.
Very briefly, yes, about visual cues and inclusive spaces. I referenced the story, and this was right when Dr. Atkins and I were starting the clinic. We had just trained the front desk staff. We were about to see our first patient, and that morning I was able to get approval for signs that were in our front desk kiosk that said, "We value diversity. Please tell us your name and pronouns." And it had a little kind of rainbow strip on it to kind of underneath "We value diversity." Well, our very first patient came in and I saw them and I did the assessment and I said, "So, we're just starting this clinic. How are things going? How's it been for you?" And he pulls out his phone, and what does he show me but a picture of that sign that I had just gotten up. And he said, "I saw this sign and I just knew everything was going to be okay and I felt safe." And I wanted to cry because I had just made all this effort and gotten approval, and it made a difference. And that's why I stress to you these visual cues, whether it's a pin on your badge or a little sticker or a sign or something, they see that and it means something. So thanks for letting me share that story, Keely.
That was totally worth it.
Thank you very much for a very informative presentation. And before we go, I think we should not let Marian Crawford to leave without giving us those digits or numbers that we need for the CME.
Yes.
Share it through the chat.
Get your cell phones out. Now you're going to text to the number you text to is 919-213-8033. And the code for tonight is J as in January, E as in Edward, B as in boy, H as in hotel, U as in umbrella, B as in boy. So Jeb Hub is the code for tonight, and you'll get your CME credit.
Thank you, Marian.
Thank you, everybody.
All right.
So thank you all. I think this was a great, great night. Thank you everyone for participating. If there are any last minute comments, please let me know. Otherwise, we will be adjourned.
Thanks, everybody. It was fun.
Thank
Thank
you,
you for
speakers.
having us.
Great audience.
No, sorry, before we go. What I wanted to say is that I hope that we can invite you guys back. That's what I wanted to say.
Yes.
Because there's
always
so much to talk about. I want you guys back. And I hope that you guys will come back.
Very good.
Well,
Only if you give us
you.
dinner.
We'll do it. We'll do it.
Yep. Oh, all right.
It was a pleasure. Thanks, everyone.
Well done, friends.
So nice to meet you.
Bye-bye.
Bye-bye.
Be safe out there, you guys. This was great.
Thank
Thank you,
you.
Keely.
Be safe.